Welcome to Mid One Pager. My name is Benjamin, and today I'm going to talk about benign prostatic hyperplasia. This is the non-cancerous increase in the size of the prostate gland, and it is going to be due to hyperplasia of the stroma and epithelial tissue. So the prostate gland, from the name, it's a gland, but it is not all just one gland. It is composed of connective tissue as well as small glands that are held within that connective tissue. So the connective tissue is going to increase in size. That is the stroma and the epithelial cells within the gland. And when these increase in size, they're going to give us the symptoms that we find in prostatic hyperplasia. So when we look at prostatic hyperplasia, it has an increased incidence with age. So the older people get, the higher the chances of getting prostatic hyperplasia. And almost 50% of people by the age 50 years, they have an increase in the size of a prostate. And 90% of people by 8 years have an increase in the size of the prostate. But the thing is, 50% of these people that have actually the increase or the histologic evidence when they do a biopsy of an increase in size of the prostate actually do not have symptoms, which is actually not a bad thing. So when we look at the anatomy of the prostate, just to understand what's really going on, before we dive into the hyperplasia, the prostate weighs around 20 to 25 grams in young men, and it lies below the bladder. So as people tend to age, this size is going to increase. And it has three zones, and this is what is the most important to understand. It also has lobes, which are 5, but for the purposes of understanding this, we start with the zones. So the zones, we have the peripheral zone, which is the outermost, and for it is the size where the cancers are going to occur, because it's where we have most of the glands. And the cancer of the prostate is going to come from the glands within the prostate. So we have the central zone, which surrounds the ejaculatory ducts. These are the ducts that bring in semen from the testicles. And then we have the transition zone, and the transition zone is going to surround the urethra. So around the urethra, certain books actually say the prostate is like a continuation of the bladder. So as the bladder, at the end of the bladder neck, we just have the prostate sitting around there, and then through the prostate, we have the prostatic urethra, the part of the urethra that passes through the prostate. So the central zone is where the transition zone is where we are going to have the urethra, and that is the site where mostly the BPH is going to occur. It's where we're going to have an increase in the size of this tissue, and it will cause pressure on this urethra and cause the symptoms of obstruction, of urinary obstruction. And we're going to look at that. So we have the anterior fibromuscular stroma, and this one has no glandular elements. So BPH usually affects the transition zone and the periurethral zone, causing compression of the urethra. Sometimes you have what we call the median lobe of the prostate, and this median lobe sometimes may increase. Now, when the median lobe is in the middle, as you hear the name, and it is at the top, so it's closer to the bladder. So when it increases in size, it is going to go into the bladder and cause what a ball valve type of obstruction. So when we look at prostatic hyperplasia, when we have increase of the prostatic gland, it's going to have different effects on the different structures that pass near it. So the first one effect is going to be on the urethra. When we have compression of that prostatic urethra, the part of the urethra that passes through the prostate gland, we are going to have increased urethral resistance, and that is going to cause obstruction. When we have obstruction, the stream of the urine is going to become weak, and then we shall have hesitancy because of the obstruction. When someone tries to initiate urinating, or when they try to urinate, they kind of hesitate because there is pressure, and then they start straining. Then we have mucosal irritation due to that compression and everything. We can have irritation of the mucosa, and that is going to cause a dysuria, and that is the pain on urination. And then sometimes we can have a urethral diverticulum from the chronic pressure. As this pressure in the urethra is high, the urethra may tend to dilate or form a diverticulum, and that is going to be seen. Then the bladder. So earlier on, when the obstruction starts to occur, the bladder is going to hypertrophy. It's going to increase the strength of its muscle, and then as it's tried to overcome the pressure, and then it will become trabeculated. So trabeculation is development of muscle, that muscle that develops, extra muscle that develops on the bladder is the trabeculations, and these trabeculations later on are going to have a weak space between them, which we call the circulation. These circulations are the ones that are going to bulge outwards. So we have what we call the formation of a diverticulum. Diverticulum is going to be like a pouch, and this pouch is going to be a place where urine will collect, and it will come up with also a very big number of problems. Then we have chronic obstruction that leads to this detrusor overactivity, and because the muscle of the bladder is not effectively emptying and everything, there's going to be overactivity of that muscle, and then we shall have things like urgency, where someone wants to urinate very many times, wants to urinate, always feels the urge to urinate. Their frequencies are going to urinate very many times, and then nocturia, where they're going to wake up in the night to urinate. You find someone is telling you they wake up 9 to 10 times at night to urinate, and this is going to cause problems because you can understand how this is going to affect the way of life of this patient, because they're going to spend a lot of time waking up. They're going to have quality sleep. Then we have decompensation in the end of the bladder, where we have an atonic bladder, a bladder that does not contract because it has been working against obstruction a long time, through the time, and gives out. So we have an atonic bladder, and that is what is going to cause a large residual urine and overflow incontinence. So you find many of these people are going to come and they are complaining that they have not urinated in the while, or they have distension and feeling a lot of pain, and you need to relieve that. And sometimes they have this overflow incontinence whereby the bladder is very full, it's atonic, then the urine just flows out. Then they have increased risk of UTIs because they're not urinating, so organisms can easily ascend through the urethra, which would otherwise be normally flushed out with the urine. Then they have stones due to that stasis of the urine, and then hematuria can also occur. And then the back pressure from chronic retention can cause a vesico-urethral reflux in the ureters, whereby the urine will go up now in the ureters back to the kidney, and we have what we call the hydroureter due to persistent high intravesical pressure, and this is going to cause a post-renal failure. So when you look at the risk factors for developing prostatic hyperplasia, normally age is the biggest risk factor. As someone gets older, they're most likely to develop a bigger prostate. Then normal testicular function is going to be a risk factor, and this is because most of this hyperplasia is driven by the hormone testosterone, and then the testicles are the main producers of testosterone in the body. So it's no surprise that normal testicular function can be a risk factor. Genetic predisposition, whereby family history, prostate family histories could be indicated. Metabolic syndrome, people who are fat, obese individuals, and people who have diabetes. Sedentary lifestyle, people who don't move a lot, don't work out, a high fat diet, and a low fiber intake. Then chronic inflammation of the prostate can be another factor. If someone is having prostatitis, they could develop this hyperplasia. Then we have the differentials. Of course, for this outflow, we have to consider things like carcinoma of the prostate, urethral stricture, because we have obstructive symptoms. So a stricture in the urethra could make sense. Bladder neck sclerosis, which is when we have fibrosis or hardening of that neck of the bladder, can have outflow symptoms. Then we have the neurogenic bladder, which is coming from diabetic neuropathy and spinal lesion, and sometimes even drugs. If you're having antimuscarinic drugs, they may cause this bladder to not tear it. Then chronic prostatitis, then bladder carcinoma should be also in question, and for it to a lot of the times be having a lot of hematuria will be predominant. So here we review the anatomy a little bit. So this is the bladder up here, this is the prostate, and within the prostate we have the prostatic urethra passing through here. We have the prostatic utricle, ejaculatory ducts are opening into the urethra right here, the seminocolicus, the prostate gland, then the sphincter. Then we move on to the pathophysiology of how everything comes into place. So what happens is that we have the hormone testosterone, and testosterone is produced from the testicles most of the times, at least most of it. And also the adrenals play a role. So when we have testosterone, is going to be converted by 5 alpha reductase into the hydrotestosterone, And this one is going to act on the prostatic stromal cells. Now, when dihydrotestosterone binds the androgen receptors, it's going to stimulate growth factors that cause hyperplasia of both the stromal and the glandular tissues. So, both the stromal and the glandular tissues are going to increase in response to this. Then estrogen levels also are going to rise relatively with age. And when we have an increase in these estrogen levels, they are going to increase again the androgen receptor sensitivity to dihydrotestosterone. And this is also going to lead to hyperplasia of the stromal and the glandular elements. So sometimes people compare this to breast cancer, where we have also adenosis, where we have the hormones estrogen and progesterone working on the breast tissue, but estrogen causes the proliferation of the breast. So something similar happens in the prostate, but if you want to relate to that, then you have the static component now. This is a mechanism of how it's going to be. And this is going to be due to an increase in the size of the prostate. And when that prostate increases in size, it's going to compress the urethra. Then the dynamic component now is due to an increase in the adrenergic tone in the smooth muscle of the prostate and the pedal neck. So when you look at the prostate is considered also somehow to have a sphincteric function, mostly the upper part of the prostate, and some people even who don't have an external the second sphincter, sometimes the prostate can confer some kind of sphincteric action there. And also the prostate has smooth muscle. Remember, the semen that is coming through the HH ducts is poured through the prostatic urethra, and most of the times we don't want it to go into the bladder, we want it to come downwards. So we have smooth muscle there that contracts to ensure that we don't have that retrograde ejaculation into the bladder. So sometimes when you have an increase in the tone of that smooth muscle of the prostate and bladder neck, we can have a functional obstruction, and the bladder is going to compensate still, as we saw with the detrusor hypertrophy, but later it is going to decompensate, will lead to incomplete emptying, and then we have residual urine. And this is going to explain why alpha-adrenergic blockers are going to be helpful in the management of BPH. So when you look at the clinical features are going to come as obstructive, irritative, and then they may have just complications of the BPH. So the obstructive symptoms are going to be hesitancy, going to be a weak or intermittent stream, and then we shall have straining, dribbling, and incomplete emptying. And this is going to come from urethral compression plus the smooth muscle tone increasing. That is a smooth muscle within the prostate. Then irritative symptoms are going to be frequency, urgency, nocturia, and this is a common triad. Frequency, urgency, nocturia, the common triad of BPH. Then urging continency and dysuria. And these are going to come from bladder wall hypertrophy and detrusor hyperactivity. Then the complications that a patient may actually present with may include acute or chronic retention, where someone comes and says they have not passed out urine, but they feel the urge and they cannot. Then overflowing continence, where now they just pass the urine without, they have no incontinence, they cannot stop it. Then UTIs are also common, where they feel pain, the stones, hematuria, hydronephrosis. Sometimes they come with hernias, and the hernias may have come from this training over a long period of time. So when we look at the investigations, we have urinalysis, where we may look at for infection or hematuria. We can do serum creatinine and urea to assess for renal function, because we said this hydronephrosis that occurs due to urinary outflow obstruction can lead to a postrenal failure. Then we want to do the PSA, which is a prostate-specific antigen, and it's going to be elevated in both BPH and cancer. But whenever we have an elevation greater than 10 nanograms per mil, sometimes that is when we want to do evaluation for malignancy and find out, do we have cancer? And sometimes we use it as a baseline before we start the 5-alpha reductase inhibitors, because when we start the 5-alpha reductase inhibitors, they're going to cause a reduction in the size of this prostate. And when they cause a reduction in the size of the prostate, we shall have a decreased PSA, because smaller prostate, less PSA is going to be produced, and the bigger prostate is going to produce bigger PSA. Then we can do the ultrasound, which we do the transabdominal or the transrectal, and we want to see the prostate volume, the post-voidal residual volume, how much urine remains in the bladder after urinating. We want to see the thickening of the wall, the stones that could come as complications, and then hydronephrosis in the kidneys. Then you have uroflowmetry, whereby we measure the flow of urine through as it comes out. And if we have a speed of less than 10 mils per second, it indicates that we have an obstruction. We can do a cystoscopy, which is indicated if we have hematuria, strictures, stones, or even before we do the surgery. Then we have the urodynamic stages to differentiate bladder outlet obstruction from destrucer underactivity in unclear cases. Then we have the management. Management can be conservative sometimes. We'll have watchful waiting. That is if we have mild symptom. That's an IPSS of less than 7. Then we can do lifestyle modifications for these people, like limit the fluids in the evening, reduce caffeine and alcohol, time voiding and double voiding. Then we can treat constipation, stop drugs that worsen obstruction like the anticholinergics and decongestants. Then we can do the medical management, where we use drugs like the alpha blockers. You said we have smooth muscle within the prostatic area. So if you give an alpha blocker like tamsulosin, which is commonly used, or alfuzosin, these are going to relax the muscle, and most of the time we're going to have rapid relief. But the problem with that is that we have these side effects that come with this, like postural hypertension. So if someone is on tamsulosin and they are also other hypertensives, sometimes they may end up with issues. So it's important that you review their drugs carefully to avoid that. And then because you're relaxing that smooth muscle, we can have retroejaculation, which can have issues with fertility. Then 5-alpha reductase inhibitors. These ones are going to prevent the formation of dihydrotestosterone from testosterone. And when that is not there, we're going to have decreased proliferation of the gland. So some side effects of that is going to be decreased libido, erectile dysfunction, and gynecomastia, because we are having low androgens in the body. Then we can do combined therapy for large glands or for symptomatic people, where you give an 5-alpha reductase inhibitor like finasteride, as well as tamsulosin and alpha blocker. Then others, we can use antimuscarinics for urgency. Then tadalafil if we have erectile dysfunction, plus lower urinary tract symptoms, the LUTS. Then surgical management indication is going to be failure of medical therapy if we have recurrent urinary tract infections, if we have recurrent infections still, if we have bladder stones or hematuria, if we have hydronephrosis or renal insufficiency, and if we have a large residual volume greater than 100 mils within the bladder post-voiding. So some of the procedures we can do is the transurethral resection of the prostate, and this is the gold standard case, whereby we have resecting of obstructing tissue using a resectoscope, and this one's going to cause rapid symptom improvement. So through the urethra, a scope is introduced, and then we have that resection of the prostate. So as the prostate enlarges, remember the enlargement is coming from the transition zone, which is inside. As the prostate enlarges, it's going to compress out the peripheral zone. So the peripheral zone is going to form a second capsule. So normally the prostate has a capsule surrounding it, but because of this enlargement, the outside is going to form a second capsule. And that is what makes this possible, the transurethral resection, because you will be cutting within the false capsule that is outside, and that is going to help reduce on the chances of bleeding and everything like that. So then we have the transurethral incision of the prostate, and this one is done for small glands, and we do an incision at the bladder neck to relieve obstruction. So when you look at the complication of the transurethral resection of the prostate, one of them is the transurethral resection syndrome, and this is going to have symptoms of hyponatremia, and it's going to come about when during the transurethral resection, we're going to be introducing a scope, but there's also copious irrigation. A lot of fluid is going to be used to irrigate. Sometimes they use mannitol and other fluids. So when they introduce these fluids, sometimes they enter the venous plexuses, within the prostate and then end up into the systemic circulation. So this is going to cause a dilution, and when we have a dilution, we're going to develop a hyponatremia, and this patient is going to produce with symptoms like seizures. They may have nausea, vomiting, symptoms of headache, as symptoms generally of hyponatremia. Then also, because there's of the sphincter contra I talked about of the prostate, we're going to have retrograde ejaculation and its problems. Then we have the open prostatectomy, which have the retropubic and the transvesical. So transvesical, they pass through the bladder, and this is called the Freya's procedure, and it's commonly done for very large glands, that is greater than 80 to 100 grams. They're going to consider the transvesical approach, and for this one, both the prostate and the prostatic urethra are going to be removed. They are going to be avulsed, and then a catheter will be left in place for some time, and the catheter will be the one. The catheter will enable, there will be formation of a new canal along that catheter, which will replace that avulsed urethra. Then we have other minimal invasive procedures like the laser operation and the enucleation, a Urolift system, which is basically mechanical lifting of the prostate lobes, the Resam therapy, prostatic artery embolization. This one's for patients who are unfit for surgery. And we have the complications of the treatment. So medically, the medical drugs, mostly we have hypertension, dizziness, erectile dysfunction, and decreased libido. While surgically, mostly we have bleeding, the transurethral resection syndrome, retrograde ejaculation, stricture formation, incontinence, and then rarely, sometimes we have erectile dysfunction. So we have come to the end of this video, where we have covered a lot about the benign prostatic hyperplasia. So the next video I'm going to cover prostate cancer. See you then. My name is Benjamin. Have a nice day. Don't forget to like this video, comment, share with a friend, and subscribe to the channel if you haven't done so.